Good afternoon. I'm glad to welcome you to a scheduled lecture on pathological anatomy. Today, we are going to discuss with you a very extensive, diverse, complex, and at the same time fascinating topic: the pathology of female genital tract and pregnancy. My name is Skoryk VR. I'm Associate Professor of the Department of Pathological Anatomy and Forensic Medicine of the Dnipro State Medical University. I would like to start with the words of the French poet of the Napoleonic epoch. There is always something new to say about women, while at least one of them will stay on the globe. Yes, today's topic is really important. I can say that each day something new is discovered, something new is statistically proved. And in support of the scientific side of this quote, I'd like to present you the latest WHO classification of the female genital tract tumors. The 5th edition of that came out a little over 6 months ago. So, let's start our journey. All diseases of female genital tract could be divided into several groups. So, first of all, inflammative. So, the main pathological process here is inflammation. The second one is hormonal. It means disturbance in hormonal level or disbalance in hormonal level. And finally, oncological. There is very interesting point. So inflammative changes could lead to the hormonal and in opposite direction. So hormonal disbalance could lead to the inflammation. And both of them, inflammative changes and hormonal changes, could lead to the oncological transformation, even to the malignization or malignant tumor formation. So, examples of inflammative diseases. Classically, we have a bacterial infection. So here on the histological specimen, after the biopsy of the cervix, we could see a lot of erythrocytes as a feature of inflammatory arterial hyperemia, and also we see a lot of inflammatory infiltrations, neutrophils, and actually lymphocytes. So all features of inflammation of the cervix, in other words, cervicitis. But there is no specific features to be sure what exact bacterial infection is it. Next one, chlamydia infection. Here we have specific appearance of the cells, and this is a smear because this is a cytology. So previous photo was histology, histological study. So this one is a cytological study. Next one, also cytology. This here we could find fungal mycelium. Here is it. So this is a fungal infection. Next one, syphilis. Here we could see Treponema pallidum. If we are talking about the smear again, and when we take a biopsy, so piece of tissue, here we could find the features of chronic productive specific granulomatous inflammation due to syphilis. So here we have a granulomas formation with a lot of epithelioid cells, lymphocytes, plasma cells, giant multinucleated cells or pyrogoff-Langhans cells. There is no or could be no caseous necrosis, but what is the most specific for syphilitic granuloma compared with tuberculosis? Presence of vasculitis, so inflammation of the vascular wall, vasculitis. Next one, Cytomanholovirus. Also, we could see a cytological study, and here we have specific intranuclear inclusions and a specific, here you see intranuclear inclusions. So move on. The most common inflammative disease due to human papilloma virus. So here we have so-called, you see this light zone, big, huge light zone. So it is called as perinuclear halo. So presence of perinuclear halo is a feature of HPV infection. Next one group is hormonal diseases. So hormonal diseases, firstly, we need to repeat the normal cycle of changes. So we have several phases. So first of all, we have proliferation, when the level of the estrogen rises, and then we have a phase of secretion, where the level of estrogen decreases but progesterone level is increased, and eventually when levels of both hormones decrease this, we have a menstruation phase or bleeding. So this is an endometrium with normal proliferative phase. So we have like pseudostratification, so a lot of like layers of cells, some mitotic figures, but cells are regular, they are similar to each other, so there is no features of dysplasia. This is classical proliferative endometrium. Next one is the early secretion stage. So here we have, you see these subnuclear vacuoles, very specific features for this stage. And lastly, we have exactly late secretion. So we see the dilated glands with a lot of secretion inside the lumen of this gland, so classical appearance of secretion. And here what exactly is wrong? So when we see morphological features, for example, of proliferation phase, but the day of the cycle should be about the late secretion, this is a problem. Oppositely, we see features of late secretion or secretion, but it should be early proliferation. Again, this is a problem. So where we have imbalance between the day of the circle and morphological features, we can name it as hormone. So the main cause of this is hormonal diseases, hormonal disbalance, and we name is as hormonal disease. So, pathogenesis. So classically, we have a disturbance of cyclic hormonal secretion. So it could be due to problems with ovarium, of problems with endocrine system, but any of these, actually each of these problem leads to the absolute or relative hyperestrogenemia. This is the most important. Yes, it is also progesteronemia, hyperprogesteronemia, but the most important is still hyperestrogenemia. And here we have, as you see, 5 main symptoms, and right now we discuss which are they. So amenorrhea, this one, amenorrhea means absence of bleedings, cycling bleedings. Dysmenorrhea, this one, when we have a cycling bleeding with significant pain. So painful cycling bleeding. Next one, menorrhagia. Menorrhagia means too much bleedings or too long cycling bleeding. Next one, metrorrhagia. Metrorrhagia means presence of bleeding or even uterus hemorrhage, not in time exactly, or not on time of menstruation phase. So according to the cycle, there is no menstruation, but woman has a bleeding. And the last one, sterility, I think this is clear. So this absolute or relative hyperestrogenemia and or progesteronemia leads to the oncological transformation. Could be benign, could be malignant, but anyway, oncological transformation takes place. So let's start with cervix. So here we have an uterus, this one. So uterus consists of 2 parts, corpora uteri and cervix. And cervix also consists of 2 parts, so-called endocervix, outside part, and endocervix, inner part. So endocervix means inner channel of the cervix. So here very good to see. So this is exocervix, and inside that one, inside channel is endocervix. So this one is exocervix, and this one, so this channel is endocervix. So where is the difference? Why do I so emphasize of this endo and exocervix? So the main difference is actually different type of covered epithelium. Endocervix is covered by one layered glandular epithelium, And exoth cervix is covered by squamous stratified non-keratinizing, it's important, non-keratinizing epithelium. And this one becomes this one via metaplasia. And we have a place that we name as junction uh, between endocervix and exocervix. But this is normal situation. And right now we discuss where is the problem. Squamous stratified non-keratinizing epithelium of the cervix. I please you look here. There is no keratin masses at all because this is non-keratinizing epithelium and this is again normal situation. So, diseases of the cervix. If we have an inflammation, we can name the process like cervicitis. So it could be acute and chronic, everything is logically. So some infections, but I emphasize again on this one, HPV infection. Next one, cervical polyp. So here we have a formation of plus tissue that shouldn't exist normally. So we have a dense fibrous underlying fibrous stroma with hyperplastic endocervical glands, and the whole polyp, I mean, you see the whole border of the polyp is covered by glandular or columnar epithelium. And the next one, important point, ectopy or cervical ectopy, or obsolete term, but you could find it in your Croc 1, pseudo-erosion or cervical ectopy, they are the same. So here, look at this picture, please. So what do we have here? So this is squamous stratified mature, squamous stratified non-keratinizing epithelium. This is glandular squamous, glandular mature also epithelium. And this is exactly place of junction when glandular epithelium becomes mature squamous stratified epithelium. And right now I please you take a piece of paper or just take your hand and close with your hand or with piece of paper left part of the picture. And what do you see? You see that we have under the squamous stratified epithelium glandular epithelium. So ectopy. So we shouldn't see in the endocervix, in the exoth cervix, we shouldn't see endocervical glandular epithelium. But we see. And that's why we name it as ectopy or cervical ectopy, or again obsolete term, but anyway you could find it pseudo-erosion. So what diseases could, I underline, not like should or definitely lead, could lead to the oncological transformation? So as I said previously, we have two groups, hormonal and inflammative. So hormonal diseases, they are endocervicosis, yes, or pseudo-erosion, or cervical ectopy. Here is another picture. So you see squamous stratified epithelium, metaplasia, squamous metaplasia, and here you see squamous stratified, and exactly or directly under the squamous stratified epithelium we have a glandular epithelium. So this means cervical ectopy, pseudo-erosion, endocervicosis. There are a lot of terms, but the meaning is the same. Next one, Lekoplekia. So I have emphasized that squamous stratified non-keratinizing epithelium is. And here you see a lot of pinkish masses, and these masses are keratin. So we have a lot of keratin on the surface of the epithelium. That's why we see right now on the slide squamous stratified keratinizing epithelium, and it was a metaplasia. So Lekoplekia by the definition is a type of metaplasia or an example of metaplasia. So squamous stratified non-keratinizing epithelium becomes keratinizing one. Moreover, there is an interesting fact. According to the modern literature, term Lekoplekia gets to used only in the oral cavity, and in the cervix there is a tendency towards using just metaplasia, so without term Lekoplekia. But anyway, you need to know what is Lekoplekia, and to be honest, we have already started with you this term in the first or second class of previous semester when we studied with you intracellular accumulation, and this is the type of so-called horny dystrophy. So this is clear. Move on. Polyp. You also have seen the microscopical appearance of endocervical polyp, and here you see exactly in the channel we have a plus tissue. So endocervical polyp. Inflammative diseases, cervicitis, it's clear, I hope, condylomas, and the post-traumatic changes, ectropion and scars. So please look here, condylomas and polyp. And both of them could be in the cervix. And what do we have? In the exocervix, exactly, or to be more correct, on the surface of the exocervix, we could have only condylomas because there is a squamous stratified epithelium, and condylomas arises only on the squamous stratified epithelium base, and polyp could appear only in the or on the glandular surface. So please do not mislead. In the cervix, both of them are possible. And then these hormonal changes or diseases and inflammative diseases with time could, not like definitely, but could lead to the dysplasia. So what is dysplasia? Dysplasia means that cells increase their speed of proliferation and they do not have enough time to mature completely and make their function or fulfill their function. That's why we have increasing. So you see increasing in size. So this light blue color, this one. So these cells are normal cells. Compare with this one, you see they are bigger, nuclei are more darker, and we can assess the thickness or part of thickness of the epithelium that is affected. So if this is just lower third, this is mild dysplasia. If 2/3 of epithelial thickness are affected, we are talking about moderate dysplasia. And when the whole thickness of the squamous stratified non-keratinizing epithelium is affected, we are talking about the severe dysplasia. So, mild dysplasia means scene 1, moderate scene 2, and severe scene 3. Scene means cervical intraepithelial neoplasia. Next point. Scene 3 and CIS, yes. CIS sometimes is really difficult to distinguish. What is CIS? Carcinoma in situ or non-invasive carcinoma. So all features of carcinoma you could find. So cells are bigger, they are different in shape and size. In other words, polymorphism, hyperchromatic nuclei, increased mitotic rate, or even a presence of atypical mitosis. But the basement membrane is safe. It is the most important key. So if the basement membrane is safe, so this is carcinoma in situ, and actually you save the life of your patient, because the prognosis, the quality of life, the next treatment in carcinoma in situ and invasive carcinoma, they different from each other significantly, too significantly. So this is the most common classification, and you can use this classification, probably you can see this classification in your CROC 1. But modern society right now is used to applying another classification when we have low-grade dysplasia and high-grade dysplasia. So moderate and severe dysplasias right now are high-grade dysplasia, and only mild or scene 1 it is a low-grade dysplasia. So here we divide the epithelial thickness on two halves. So if we have increased in size, hyperchromatic, different in shape probably, cells only in the lower part of the epithelial thickness, we are talking about the low-grade dysplasia. If we could find these not normal cells even in the upper part or through the whole epithelial thickness, we are talking about the high-grade dysplasia. And dysplasia is a pre-step of cancer. So dysplasia is going to be malignant tumor. Not like probably, maybe, might be. No. Dysplasia is going to be malignant tumor. In this case, is going to be squamous cell carcinoma. Also, I state on the cause. So HPV infection has a lot of serotypes, and not all of them lead to the malignancy. There are the most important or the most oncogenical 16 and 18 serotypes, and exactly accumulation enough of them could lead to the malignancy. What do I mean accumulation? So it is like infectious overload. So as more pieces of this virus accumulates in the cell, as higher risk of malignancy. Move on. So dysplasia could lead to the carcinoma of the exoth cervix and of the endocervix. Carcinoma of the exoth cervix has an exophytic type of growth, so it grows like outside from the organ, or it goes or it directs into the cavity. And microscopically, we are talking about squamous cell carcinoma. So you see exophytic growth outside from organ. And microscopically, we have our classical squamous cell carcinoma with keratinization with these pinkish roundish structures. They are pearls formation. And endocervical carcinoma has logically exo, endo. So endophytic types of growth, so it grows inside the wall of the organ. And classically it is adenocarcinoma because in the endocervix we have a glandular epithelium, and glandular epithelium is a source of adenocarcinoma. So here you see the tumor inside the wall of the cervix. Exactly, yes, you see this one. So endophytic growth. And microscopically, you see what? You see glands. Yes, they are atypical. They contain atypical cells, significantly atypical cells, but we still could recognize glands. That's why this is adenocarcinoma. Move on. Corpora uteri. Corpora uteri has 3 layers: endometrium, myometrium, and serous layer. So, first of all, we're talking about the endometrium. Again, logically, we could have an inflammation. Inflammation of the endometrium is named as endometritis. It could be acute, it could be chronic. You see the list of the most common diseases, so let me not to name it again. And we move on. Endometrial polyp, one of the most common result of hormonal disbalance in woman's organism. So here we have mostly the same that we have described with you in the endocervical polyp. So here we have instead of dense fibrous stroma, we have an endometrial stroma, but also with hyperplastic glands. Some of them are cystic dilated. Also we have, it's very important, vascular pedicle. This one, vascular pedicle. So because of these vessels, this polyp actually had arises and right now survives. And please look here, the whole border of the polyp is covered by glandular epithelium. It's important. So this is a polyp. Move on. Endometrial hyperplasia, classically associated with prolonged estrogenic stimulation of the endometrium. Classically. And please look you at the top of the causes. So probably 10 years ago we put the menopause on the first place, but today you see that obesity has already taken this place because we have a statistically proved result or a statistically proved evidence that obesity leads to the malignancy in the endometrium, so adenocarcinoma of the endometrium, and in the breast, so adenocarcinoma of the breast. So here we see the normal endometrium. So you look at the distance between cells. And right now here we see the hyperplasia of the endometrium. So cells are close and distance between them is significantly smaller, or the cavity between them is narrow that it should be. We have a histological symptom, so back-to-back glands. You see they are too close to each other. Firstly. Secondly, this is non-atypical hyperplasia. But the last slide is atypical hyperplasia. What does it mean, atypical hyperplasia? It means endometrial hyperplasia plus dysplasia. So the main pathogenetic way looks the next. So we have hormonal disbalance, then we have endometrial hyperplasia, then we have atypical endometrial hyperplasia, and then we have adenocarcinoma. So it's very important to read carefully your MCQ condition. Is there any features, classically complex of features, about the malignancy, about the atypism, about the dysplasia? So again, I repeat for you. So we are talking about the increased nuclear cytoplasmic ratio, hyperchromatic nuclear, increased mitotic activity, even presence of abnormal mitosis. If we see this abnormal mitosis, your first thing should be about already malignant tumor. So hyperchromatic nuclear, they are bigger than it should be, they are different in shape, in other words, polymorphism. So here we have non-atypical endometrial hyperplasia, and here we have atypical endometrial hyperplasia. Move on. Pathogenesis. So premenopause, anovulative cycles, absence of yellow body, and we see that we have hyperestrogenemia. So this hyperestrogenemia actually is a key for a lot of problems. And there is a list of risk factors, and you see that they are mostly the same, that a list or with a list of causes of endometrial hyperplasia because of that pathogenetic way. So endometrial hyperplasia could probably become an atypical hyperplasia, but atypical hyperplasia is going to become adenocarcinoma. So background diseases, atypical hyperplasia of glands and polyposis of endometrium, because in the polyp we could also find problems with dysplasia, could. So gross spacement, so you see these plus tissues in the lumen of the corpora uteri. These are polyps. And please look here, this is a bit different picture. This is adenocarcinoma grossly, and right now you could see it microscopically. So this part of the slide is about normal endometrium, and this is adenocarcinoma. Please look, there is no stroma between glands, no stroma at all. It's important feature of malignancy, and all features as you, I hope, used. So increased mitotic activity, polymorphism, hyperchromatic nuclei, presence of abnormal mitosis, polymorphism, so the cells are different in size and shape. So, carcinoma of uterus has an exophytic growth. So, classically, as you have seen, it grows inside the lumen of the uterus. And microscopically, we are talking about the adenocarcinoma. Next one point, endometriosis and adenomyosis. So, we have uh, presence of endometrial tissue, stroma this is stroma, with or without glands. And we have this focus of endometrium outside of endometrium. The most common location is myometrium, but this is it should be one like exception, or not like exception, one evidence. So these foci should be far than 3 millimeters from endometrium. In this case, it is adenomyosis. So no less than 3 millimeters. Next one point, chocolate cyst. It's a classical question in your MCQ test. So, according to the origin, this cyst is an endometrial cyst. So, endometrial tissue present in the ovarium. Because this is an endometrial tissue, so all cyclic changes happen with this endometrial tissue, and with time, after probably a lot of cycling bleeding, we have a formation of this cyst with these dark brownish like masses inside. So the most common site of endometriosis is an abdominal cavity, and endometriosis results in dysmenorrhea. Actually, there is a lot of pain, pelvic pain, and unfortunately infertility. Move on, myometrium. So here we have leiomyoma and leiomyosarcoma. So the first one is benign, the second one is malignant. And leiomyoma is the most common problem with myometrium due to the hormonal disbalance. So benign tumor has no features of cellular atypism, and oppositely malignant tumor has all features of cellular atypism. So the tumor cells in the leiomyoma, they are similar, you see, in size, in shape, they look mostly the same. Also, there are some connective tissue, you see, between cells, so some space between cells, and hyalization is present as well. Leiomyosarcoma oppositely. Cells you see are different in size, different in shape. There is mostly no connective tissue between them. It means hypercellularity, so increased cellularity. According to the location of the nodules, they are divided into 3 groups: subserous, intramural, and submucous. So subserous, when, as you see, so nodule locates directly under the serous layer. Intramural means that inside the myometrium, and submucous directly under the endometrium. And exactly these nodules are the most problematic, and they result in pain, in menorrhagia, and even metrorrhagia. Move on. Breast pathology. Breast pathology, it's a a really huge part of female genital tract pathology. It's so massive, so WHO has revealed a separate book about the breast pathology. So remember, at the beginning of the lecture, I show you the newest WHO classification of female genital tract tumors, and around the 2 years ago, WHO has presented a book, you see, not like a part or of book, the whole uh, book about the breast pathology, exactly tumors, malignant and benign, and pre-tumors. So, for you, what do you need to know? First of all, inflammation of the breast is mastitis. It could be acute, and classically, if we are talking about the acute mastitis, it uh, it is associated or it associates with lactation. Also could be lymphocytic mastopathy and granulomatous mastitis. Between acute mastitis and lymphocytic mastopathy, there is a huge difference. Due to the acute mastitis, we have domination of the neutrophils, and lymphocytic mastopathy, oppositely, has a domination of lymphocytes. Next one, non-proliferative breast changes or fibrocytic changes. So in your croc, in your MCQ test, you could find these fibrocytic changes, but the modern name is non-proliferative breast changes. They are cyst formation, fibrosis, and adenosis. If we have non-proliferative, so it is obviously that we should have proliferative, and here we could have with atypia or without it. Moreover, look here, papilloma. When we have studied with you the terms of tumors, we have studied that we have benign tumor from squamous stratified epithelium, and the name of this tumor is papilloma. Yes, you are absolutely right, but in that case, that is squamous papilloma. But in the breast, we also could have papilloma. So please do not mislead yourself. Everything is okay, and this is possible. And also here we have sclerosing adenosis. So some pictures for you to see what we are talking about. So sclerosing adenosis. So we have a lot of connective tissue, and the ducts are close to each other, and in some cases exactly this picture is very difficult to distinguish from invasive adenocarcinoma. But this is still benign. So hyperplasia of the ductal epithelium, hyperplasia of the lobular hyperplasia, and this is finally, you see, in the big duct we see a papilloma formation in the breast. Fibroadenoma, next disease, next tumor of breast, and this tumor is the most common not only in the real life, but is the most common question in your MCQ test about the breast for sure, and probably about the whole female genital tract pathology. So fibroadenoma is the most common benign tumor. What is a specific feature of it? This is a biphasic tumor. Let's see what does it mean. So benign tumor, you see the easily defined borders. This tumor is classically dense because of a lot of connective tissue, and right now see why does it have a lot of connective tissue. So there are two variants. The first variant is pericanalicular fibroadenoma, when we have proliferation of connective tissue of stroma and the proliferation of the epithelial component. But epithelial component dominates on the stroma. And intracanalicular variant, when connective tissue, as you see, dominates on epithelial component. So biphasic tumor means that both components, epithelial and stromal, proliferate. Move on. Breast carcinoma. Risk factors. So again and again, estrogen, so hyperestrogenemia, and obesity is a factor or is a cause of this hyperestrogenemia. Move on. So forms: thyroid, ovarial, adrenal, and involutive. Next one. Classification: pathological. Yes, so exactly according to our subject. So macroscopical forms: nodular, diffuse, and carcinoma of areola or Paget's disease. If you see problems with areola, your first thought should be Paget's disease. It's like a crucial. Histological forms: non-infiltrative or invasive, intralobular, intraductal, and infiltrative or invasive. And separate type is Paget's disease. So breast carcinoma, what do we see here? So this is non-invasive lobular carcinoma or intralobular carcinoma. So you see there is a saved basement membrane. It's a cornerstone. It is a cornerstone. Saved basement membrane. This is intraductal carcinoma. Again, non-invasive. Yes, say the basement membrane is safe and all cells grows inside the lumen of the duct. One more picture about the non-invasive ductal carcinoma. So basement membrane is saved. Invasive lobular carcinoma. So cells make just a line, like small snakes, or like a necklace. So you see, just one by one. This is invasive lobular carcinoma. And this is invasive, the most common type, invasive ductal carcinoma. Invasive ductal carcinoma, as you see, resembles the normal ducts, or prevent normal ducts, but logically and obviously this is a malignant tumor, and only because of this predict because of this imitation, we could say that this is an adenocarcinoma. Move on. Paget's disease. So in the squamose stratified, keratinizing, you see, keratin masses. Keratinizing epithelium of the areola. We have this big, huge, here will be bigger higher magnification. So, big, huge cells with huge nuclei. Oh, look at this cell. There are two, and this nuclei. Look at this. So there are two eyes and a closed mouth. It looks like face, isn't it? Okay. So big, huge cell with a lot of cytoplasm and big nucleus. And these cells, as you see, mostly locate in the lower part of the epithelial thickness. We have a specific stain for this situation. Immunohistochemical study could reveal for us these cells with marker HER2-neo. So these brown sharp borders are cellular membrane of the tumor's cells. So you see how many are there in the thickness of the epithelium of the areola. And last part of our today's lectures, diseases of pregnancy. So these diseases consist or contains four main directions. So first of all, gystosis. The next one, non-carrying of pregnancy, ectopic pregnancy, and trophoblastic tumors. So let's discuss them. So gystosis, we have two main variants. We have early and we have late. Early gystosis is accompanied by vomiting of pregnancy, hyperemesis gravidarum, and dermatitis, also ptyalism. And but this is it's important and has clinical meaning, but the most severe complication of pregnancy, the most severe, we are talking about the death of both mother and future child. When we're talking about the late gystosis, and here the most important are preeclampsia and eclampsia, and right now we discuss what are they. So in modern society, preeclampsia is a systemic syndrome characterized by widespread maternal endothelial dysfunction that presents during the pregnancy with, as you see here, hypertension, edema, and proteinuria. It occurs in about 3 to 5% of pregnant women. While the exact mechanism leading to development of preeclampsia are still being investigated, unfortunately, it is clear that placenta, here you see placenta, plays a central role in the pathogenesis of the syndrome, since the symptoms disappear rapidly after delivery of placenta. So there are three main pathogenetic directions. So first of all, we are talking about the abnormal placental vasculature. So you see the thickness of the lumen of the artery. Just compare in I think no less than in 3 times in normal situation it should be wider. Next one, as I have already said, we have an endothelial dysfunction, and we have an imbalance of angiogenic and anti-angiogenic factors. And finally, actually, I can't say that's the most important, but at severe stage, we can say that it could be as the most important. So we have a coagulation abnormalities. So preeclampsia is associated with a hypercoagulable state that may lead to formation of thrombi in arterioles and capillaries everywhere in the body. And this thrombi makes worse the hypoxia of all tissues that were already in hypoxia because of the vasoconstriction and because of the hypertension. And what is the common question in your MCQ about the eclampsia? So what is the main problem? What is the main severe complication of kidney due to the eclampsia? And this is obviously acute renal failure with, as you see here, necrosis of the nephrocytes in distal tubules. So, move on. Hidatidiform mole. So, this disease is an example of gestational trophoblastic disease. And hidatidiform moles are important to recognize because they are associated with an increased risk of persistent trophoblastic disease, or in other words, invasive mole, or even Horion carcinoma. So, hidatidiform mole is divided into two types or subtypes, complete and partial mole. And we have some histological differences, but the most important is genetical difference. So, complete mole always have a diploid number of chromosomes, especially there are 2 sex chromosomes. And partial mole always has triploid number of chromosomes. So there are no less than 3 sex chromosomes. Histologically we have an edematous changed chorionic villi. Edematous changed chorionic villi, as you see here. When all villi are changed, it is complete mole. When just part of them, this is partial mole. But again, I repeat, the most important, this is a genetical profile. If there are 3 sex chromosomes, so it will be complete mole anyway. Macroscopically, you have this tip, bunch of grapes. What does it mean? You see the thin wall, the cystic, you see cystic grape-like structures. So these are exactly edematous changed chorionic villi, and they are too many. That's why they look like this, like grape, actually, bunch of grapes. So you can use this bunch of grapes for you, like a tip to understanding that this is exactly hidatidiform mole. Ectopic pregnancy. So, the most common localization in salpinx, I think, is clear, and the most common cause is an inflammative diseases. So, after the chronic, or after due to the chronic salpingitis, for example, there is a problems to actually carry pregnancy, because there is a huge risk of ectopic pregnancy exactly in the salpinx. So, next one, the fate of this ectopic pregnancy when we're talking about the fallopian tube. So it could be tube abortion, but the most classical, unfortunately, complication is rupture of the tube. So what do we see histologically and microscopically? So this is an embryo, and this is huge rupture of the fallopian tube, and this rupture led to the hemoperitoneum. Microscopically, so this is tubular epithelium. This red something actually are erythrocytes, and they are here because of the rupture. And this is chorionic villi, and you see they are small. There is no empty space inside, so there is no water edema, yes, inside. So normal chorionic villi, but unfortunately they are in the fallopian tube, and there is no possibility to growth and rise of the embryo. And the last point that we discuss with you today, this is non-carrying of pregnancy. So you need just be aware about what is abortion, premature births, spontaneous miscarriage, and their causes. So could be, as usually, hereditary factors, genital and extragenital, everything is here. I'd like to emphasize on the next point. Premature births, we are talking about the delivery before the 37 weeks. And if fetus has more than 100 gram weight, so this fetus is going to be saved. I mean, so doctors start to save it. The high percent of this fetus unfortunately die. But if we have weight 500 gram, so we have to try to save it. Okay, for today, that's it. I appreciate that you were with me in this topic, that you have tried to get into it. So I thank you for your attention, and I wish you to stay healthy. So take care of yourself, of your relatives and neighbors, and obviously today this is the main task, to stay healthy and to try to keep yourself and your brain in direction of knowledge accumulation. I can say like this. So, see you next time. Have a nice day and stay healthy.